makes a lot of sense, because we do know that these agents are associated with some toxicities. Steve, can you tell us a little bit about the toxicities that you see with vandetanib and with cabozantinib, and how do you manage those?
So most of the toxicities are predictable from the mechanisms of the drugs. The anti-angiogenesis inhibitors have as common problems diarrhea, certainly, and that can be particularly problematic in medullary cancer patients who have it already from the disease. So sometimes it improves in response to therapy, sometimes it worsens. It can be that much more difficult to treat. Hypertension, which can really be a very critical problem, and I think early on with these drugs was under-recognized and under-treated, but patients can get into serious neurologic or cardiac complications. Vandetanib has risk for QT interval prolongation, and those patients need to be very carefully monitored by their electrocardiogram and have their electrolytes adjusted to reduce their risk of QT prolongation. There are cutaneous side effects and mucositis, some of the rash problems, photosensitivity with vandetanib. But also the anti-angiogenic properties make them somewhat susceptible to certain significant and acute complications like perforations in the intestine and tracheoesophageal fistula formation, especially if the patient has had an irradiated neck. So these patients need to be very aware of the broad array of mild and serious complications that are possible and carefully monitored in a standardized way.
So it really becomes a question of a risk-benefit analysis, and clearly there's some patients that are at high risk for progression and development of symptoms or other sequelae of their disease that we have effective treatments, and then there are other patients that the toxicities associated with therapy probably wouldn't be worth taking on.
Absolutely.
Yeah, I think one of the more common conversations Eric and I have was say, okay, technically the patient has fairly big volume disease and it's growing, but is it growing fast enough to do something? And even those, we just have to look at the pictures together and try to say, to me, I think that's the toughest decision for me to make. If they're stable, it's easy. I'm comfortable watching that. It's when they're progressive, at what rate of progression do I say, okay, for your particular case, then the benefits outweigh the risk. And I still think that's one of the most difficult decisions we make either individually or as a multidisciplinary team that may differ a little bit among us when we all see the same patients, because it's still that little nebulous.
And it differs from patient to patient too. You know, there certain patients have a need to treat and are just unable to live with the threat of their disease looming. And when they're going to be perfectly fine, I tell them, you're going to be perfectly fine. No, we're not going to do it no matter what. But there are people who, where you know, from a clinical point of view, when I'm on the edge, if it's a patient who really is going to be just more comfortable doing something about their disease, then I think it makes sense to treat. When it's a patient who really doesn't want to have the side effects, if they can live without it for the time being, then those patients I tend to follow, I'll follow them carefully so that I don't lose that window of opportunity.
So there is a gray zone of exactly when you start. As a ballpark, we look at it and certainly have introduced the topic when we have patients who have metastatic lesions that are in the 1 to 2 centimeter range or larger, and growing by 20–25% over the course of a year. Roughly the eligibility criteria that we used in some of the clinical trials, we find actually in practice are very useful in guiding us in therapy.
And as Lori pointed out, the patients are an important part of this. Mm-hmm. When we design a slide that has our multidisciplinary team, the center's the patient. Mm-hmm. So they have to be part of this decision with us, and they have to be part of the discussion, because when we're on the borderline, they're willing to accept risk. It's not my willingness, it's theirs. So their willingness can sort of push us one way or the other in the people that we truly think are on the borderline.
So it sounds like it's a really very individual approach, patient by patient, taking into account all of these factors.